This is very, very, very important. Extremely important. This is probably the most important slide that I got. No. An overarching goal is a life worth living. Well, let's ask the audience, what are their passions in life? What is life meaning to them? All right, I'll start with Sue because I know her. So sufficient funds for her needs, so being able to travel, and being able to be effective at work with a good staff. That's her life worth living. Let's have somebody else. I'm going to pick on people I know, so I'm sorry for having known you. Alan, what's life worth living for you? I mean, what is that makes you the drive? So you enjoy fishing, hunting and whatnot, and that is an additional thing that, so for Sue, that may not be that important, but for Alan, that's important. All right? I want to have one more potential Kenny. You are seeing a common theme of some stability in life, some fiscal security, some ability to enjoy our jobs and whatnot. Well, that's very important. If we don't have a goal and something to look forward to, life is not worth living. Yesterday, about 4 o'clock, I was talking to one of my patients, and I was saying, what's life for you? And she said, I don't know. I said, is there anything that you would like to do in your life that's worth living? And she said, I don't know. She was struggling to find a reason to live, and therefore, it was very easy for her not to live. Okay? But as I worked towards and then kept fishing, we are different kind of fishermen, I began to realize, she had a boyfriend, she broke up. She said, I want to have a relationship, I'm very lonely. I'm very lonely. I don't have anybody that I can rely on in my life. I'm very lonely. But there was a intent to have a relationship as one of her desire. Her boyfriend had given up, then he called again, and she didn't know where that stands. Okay? But I'm trying to find that golden nugget, which is life worth living for her, because I'm not going to give my reasons for her to have a life. Oh, I think you should go and fish. I think you should go and travel, because Sue likes it, and Alan likes it, and Ken likes it. It's not her goals. She has to have her own goals. That's my bait. Okay? And you have to have the patience to get that little fish from an individual patient, because they may be giving you all the flag, I want this, I want Purple Heart, I want book, I want this, I want that, and all this kind of a jazz. But you got to find what they really, really want, and once you get that, you are a successful clinician. It's a startup of a beautiful relationship to work with an individual, and often we are giving them things that they don't really want. They don't even care for. It's not even, it doesn't even amount to them. And that's one of my most important slides. I pride myself being a very good diagnostician. I sit down with people, I listen to them, I try to find this little fish. Okay? If you spend very little time up front, you're going to be fishing for very long, and you will have a lot of chaos in your life as clinicians. Okay? And I cannot overemphasize how important this is. Listening, not talking to the patient while they're talking. Listening. It's very different when you have your mind going in 20 different directions, and you're trying to listen, do this paperwork, and cursing the whole system for all this paper, and then saying, oh my God, I got to do this, I got to do this. Hurry up, Mary, tell me more about that. I got more people to see. Mary is not going to give you this golden nugget. She already knows that you as a caregiver are pressed for time, and you have 20 minutes to spare, and then that 20 minutes, she's not going to blurt it out. I can guarantee that she would not. But if you really care and connect with a human being and come down to earth, yesterday one of my most difficult patients, I sat down with her. She was sitting in a chair, and I sat down with her like this. Okay? She was in an important position and I was on the ground. A very important symbolism of she is important to me as an individual rather than me standing here. No, what else did you do today? Okay. The symbolism of how we get the information is very, very important, and I really want to emphasize this point. But once we get this golden nugget, we are flying high. Then we are dancing. Just for a moment here, even though its origin was from borderline personality spectrum treatment, it is getting wider usage in other settings as well, including criminal justice system where people have a lot of difficulties with behaviors and whatnot, depressions and other kind of personality issues as well. So it really has applicability which has broadened itself in more fields than not. And I, in my own practice and in the field, we are beginning to see, the research is beginning to, come around to be expressive of that. I just brought this slide just for you to keep there. This is a very medically modeled definition of borderline personality. Intense relation back and forth, this and that, back and forth and whatnot, frantic efforts to avoid. It really just does not talk about the emotional dysregulation piece, which is the cornerstone of how we then treat it differently, and it'll become more evident as we go on. So it really outlines in a very dry manner the criteria for why people are diagnosed and in what manner. But it really does not give it a soul, in my opinion. As I see it, it's a very dry, a version of life of what it is. Let's see. Okay, so Marcia talked about some of these emotional dysregulation. You'll hear these words over and over again, though. Could anyone over here help me experience their emotionally dysregulated moment? When you really, really are angry and were really upset, and what was that like? Think of, I'm going to have to pick on 2 people at least, because I like that. It's a dialectic. Inability to think straight. Okay, describe me the situation first. When you really wanted to kill somebody. Well, it's okay. I mean, nothing is recorded. I mean, when you're really, really angry and upset, just describe that for us.
The situation?
Yeah.
I don't know, maybe a personal situation at home, maybe an argument with my husband.
Well, that's very nice. He's still living, though.
Yeah.
Okay. That's fine. That's fine. Then you can proceed, please. Yeah. She's saying her colleague is saying, I haven't seen him in 2 weeks.
Maybe an argument with my husband where he's the type of person who really, when we're having a discussion, he doesn't want to discuss anything. He kind of shuts down and doesn't want to talk.
That's how most men are.
Right. So it's hard to go any further with that. So you get to the point where, when a person doesn't want to talk about something, you kind of have to walk away too. But then you get so angry and upset, you have so much more to say that you get so upset you can't think straight. Then you have all these emotions inside that you have more to say, but nobody to say them to, because he doesn't want to talk about it anymore, and he usually just gets mad and leaves.
Okay. And in that state of mind, how long does that last?
Well, it depends. It can last a few hours, or it can last overnight, because he works over the road, so he can leave and take that with him.
Okay. So it can be a few hours to a whole night thing.
Right.
Just imagine a patient who lives their life just like that. Not an overnight issue, not a 2-hour issue. It's a everyday 24-hour issue. They're sleeping and dreaming the dysregulated state of mind, and they are continuously in a dysregulated state. you think you can expect them to be reasonably having a beautiful conversation with you? You know? So when you're that angry, you think you'll be very respectful to our conversation. At that time, you say, get out of here. You know, I need some time to calm down and be collected. So that's very important, that how and this is a biology, it's a brain dysfunction almost, which takes over. So it's an emotion in your situation, but for them, it's a way of life. It's a way of life, and it's kind of very sad. And out of those come all these chaotic relationships and whatnot, and then the whole bit. Parasuicidal impulsive behaviors, you know, so no matter what you're saying and doing, you know, who cares? You know, they're in their, you know, angry mode. Important. People do kill themselves. It's not always attempts. You know, out of those attempts, some seriousness do occur. And it's the clinic job, a physician's or the clinician's job to figure it out when it's serious and when it's not. And over the years, you know, now I have developed my hunches when I can live with people doing this. And, you know, well, you can go home, I'll see you next week. And I even joke with them. I say, you know, I don't work with dead people. You come back alive next week, I'll see you. If not, I'll read about you. Now, I'm not saying that they should kill themselves, but I know them well enough to know that they will live longer than I would. You know, because I have developed that sense of clinical judgments. And there are others who won't even tell me that they're going to hurt themselves, and I'm getting that vibes from them, that I'm very uncomfortable. And over the years, you all clinicians begin to have that weird feeling. I'm so concerned about this Mary, that she's saying everything right to me, but it's not the right thing. And so the words aren't as much as is your own feelings and the energies that flow between people that also play the role. So people do kill themselves. That's my point. And then they're going to happen in your lives. I was with a psychologist who sent me patients, and there are two people at this time that he and I worked together. They're both overdosed, and they were both in the hospital. And he was very uncomfortable. I'm not. I've seen hundreds of overdoses. I've seen 15 people of those I have treated that kill themselves. And I come to recognize, no matter how hard I try, sometimes I cannot save people's lives. Not that I don't want to, sometimes I just can't. So in the slides, you will see DBT and treatment as usual. And again, that all is coming from Marsha's research. I'm just kind of being a, and I'll give you, in general terms, as the slides move on, what happens is that when you begin to work with a patient, your costs go up, okay? Because you are spending a lot more time up front with an individual. So via that, be in the hospital setting or in an outpatient setting, no matter how you, or if you pull everything together. If you begin to use these treatments, the people begin to initially, it seems, show almost like when I use my medications, a lot of times people get worse before they get better. You know, it seems to be the standard. It's almost like taking an antibiotic. You give an antibiotic, you just don't feel well in a day. You know, you take it for 4 or 5 days, and then your fever begins to subside. Unfortunately, our antibiotics take 4, 6, 10 weeks, months, but they begin to have an impact gradually and surely so. So I want to kind of talk about some of the. So when people had, it's a 1-year follow-up of whatever trial that is. DBT had higher something scores, must be GAF scores, yeah. DBT had less parasuicidal behaviors, less anger, better social adjustment during initial 6 months of follow-up. DBT sign symptoms had fewer psychiatric inpatient days and better interviewer-rated social adjustment during final 6 months. So if you study these patients over a period of time, when you apply the skills that you will be learning, the one that you already learned today was the being mindful, and there'll be more mindful things that'll come around. When you begin to apply those skills, people begin to have less parasuicidal behaviors, And all of these things get better. And the research has proven that beyond doubt. Simple but effective. I mean, I used to be an HMO medical director at one time, and we could tell the difference. Somebody's going in the hospital, 20 times, 15 times, 30 times, and whatnot. You begin to have effective treatments in place. It begins to gradually calm down. 4 admissions in a year, 2 in a year, 1 a year, and then, smaller admissions as well, rather than chaotic admission, smaller effective admissions, and then people begin to get better. So treatment as usual, the costs, it just picks up the costs. DBT is costing you more, treatment as usual is less, and the group therapies and all that kind of stuff. But if you add up all those dollars, the inpatients and the whole bit, you still are spending more money in this treatment as usual as we know it today, versus if you implement these kind of a model. So we as caregivers just cannot say it's a Latrobe Hospital problem, or it is, the thresholds problem. These folks will make your life miserable if we don't work together. All right, because their lives are miserable, so would be yours. And then if you learn the tools, no matter which setting you're in, you can begin to implement those tools, and then they will begin to build upon that. So if they are here in threshold or in crisis mobile and whatnot, and Sue gets down to the business of doing those skills, and then they're not still well, they end up in Latrobe, well, then you do the same thing with them, and they get out of the Latrobe, and they say, well, they're still not better, they come to Torrance, we're doing the same things with them as well. Somewhere along the line, you begin to have that basement taken care of, that basement which was on fire, and it begins to click in, and that's why we are doing what we are doing, because if we send patients out to you after they're successfully better, and you don't know what you need to do as a follow-up, you will be frustrated, all right? And if you're doing something and we don't maintain on our side, then you would be frustrated because we are not being able to have those skills. So this is one of the beautiful things that, some of these, and these are, a year, 4 years, 2 years, follow-ups kind of things. I'm going to maybe get one or the other study to make a point. So it's really even effective for opioids and cocaine and the amphetamine and the drug addicts, because let's face it, folks, there's no one clean borderline phenomenon out there, right? You will see shades of gray of overlapping eating disorder, some criminality built into that, somebody using drugs, and all that kind of a jazz. So practically speaking, there's no one person saying, I'm the borderline of DSM-4 revised. Now you apply DBT on me. So look at the dropouts and those kind of phenomena as well. And essentially speaking, the main parameters that we do, the global adjustment, the social adjustment, and all of the above, these folks do well with this treatment much better in all those scales. Okay? So in various scales, this is one of the parameters of checking their dirty urines, who is using whatnot. So the folks who were in DBT treatment had a lot better and cleaner relative to those who were in treatment as usual. So it makes a difference in folks who are even in substance abuse treatments, but they may have that underlying structure. I run a methadone clinic, and I see folks, who have extreme challenges, and then I can either continue to give them the pills, that's the habit forming something else, but my staff is now learning these skills so that they can be effective with them and help them grow. But it's a bigger task, though. But my point is, it's shown by research. It's dropouts. So treatment as usual, and when you're doing DBT, there's significant less dropouts because the DBT therapist is far more stickier. It's like a gum, It just won't leave you. And I used to be in that mode, well, if she isn't coming up, to hell with her. I got so many other people I can see. And Diane and I used to run a program at UPMC, and I said, no, Diane, you just don't let people go. And I now recognize it was, you call them up, come on back in, what's going on, what's the barrier, what's happening. And little by little, you begin to get them back into the treatment, whereas in a traditional setting, I used to be actually very happy they dropped out of treatment. Thank you. I said, thank you letter. My staff would thank you. Will send me a bouquet of flowers. Right? So it's a very opposite kind of reaction now that we are saying, well, come on in, because everybody else is sending them thank you notes and, when they drop out. You had not shown up for your appointment. We are so sorry, but you had to do what you had to do. All right. Mean number of sessions during the year by condition. DBT uses more sessions, my friend. There's no question about that. And then it's more intense. It's more hard work. And that's the way it is. Individually or wherever, it's more intense work. So if you're not up for intense work, you'll be saying, where did I got myself into? I'm going to go through these slides like a breeze. Let's keep moving on. But it's good for you as information to make an argument among yourself and with others as a resource. That partials and others, it works in partial hospital setting, outpatient setting, clinical setting, acute hospital setting, and so forth. And so they have done comparison between all these jazz and, I'm not a researcher, so I'm not even going to bother with that. Pharmacotherapy. All right, well, that's my favorite, but not moving as fast as I'd like it to be. Okay, well, that's a couple more important slides. And this is original. This is my own slide, kind of, my computer, after it got fried. This is how I view treatments now. I didn't a few years ago. This is how I view it now. You all own a computer someplace in the lawn? Okay. Who has the oldest computer given by their agency? Oldest computer. You have an oldest computer?
I used
Oh,
to.
you used to, okay. Who else? We have an oldest computer back there? Like 5 years old, 6 years old?
10 years old.
Oh, 10 years old, okay. How is that computer testing your patience?
There are ladies present.
What's that? Yeah.
There are ladies present.
Ladies present, okay. Dr. Hoffman refuses to say what he wants to say in the lady's presence. Okay, so his emotions are felt. Okay, so how does that make you feel, that computer? Angry and inefficient. Now, 5 years ago, it was pretty fast and pretty up to mark, right? If on that computer, you're trying to play one of the newest software that you have known, what is going to happen? It would not even work, okay? I see human beings and my medications anymore almost like upgrading their software, hardware, okay? So if in place of your computer that you had, I say, okay, fine. Let me get you a brand new Dell. I have no working relationship with Dell. To replace your old computer, and maybe this little thing then will be more effective and running it more efficiently. Without effective management of people's depressions, psychotic symptoms, their severe anxieties, their sleep difficulties, and their mood disorders, you cannot be effective in DBT, okay? So I got to do the hardware upgrade, okay? I must make sure that they're sleeping well. If they had a terrible night, and in the morning you're having your session, it's not going to be an effective session. When you had a night when you didn't sleep well, how effective were you with your husband? He was the cause, though. So one must recognize the importance of medications in DBT, that they bring that stability and upgradeness where simple things, very, very simple things, sleeping. I mean, the first thing I ask my patient is, how are you sleeping? Sleeping too much, you cannot work with them. You know, they're sleeping during your session, all right? Your whatever. And then if they're sleeping very little, that they cannot be effective either. Their mind is everywhere, right? So simple thing as much of a sleep, a proper nutrition, you know. Did you eat your meal? You know, simple things. And combined with some upgrades that we know, and I'm not going to go into those details, there are very effective ways of helping people with their depressions if we work with them consistently, and also with their mood disorders and whatnot, and that's something that must be done for the DBT to be effective. Diane and I work together in the office. She will come down someday and she'll say, I just cannot work with this individual. I really cannot. You know, I mean, she's drinking, and she's also not taking her medications, and there's nothing I can do with her because no matter what I do, it doesn't seem to go anywhere. So it's very important that you have a clinical setting where your physicians or other parameters are able to handle those phenomenons, or DBT would become almost like a new software on an old computer which would not run it properly, and you would say it's not effective. So I just wanted to emphasize that point. So it kind of goes down to the software is DBT, and first we have to give you that software, and then you will use it. Well, we'll just kind of move on from here. Diane kind of brought that slide before. You'll see some of us repeating ourselves, and I would say that if here I'm doing my pharmacotherapy, the fire, my role often becomes helping them with their agitation, and then it's soothing that up. And Lynn has often, you know, she will come down in the morning and say, Dr. Chaudhry, I really cannot be doing anything with this individual. How often have you said that? You know, does that happen?
Yeah.
It happens. And then so I'm trying to get those fires down by the molecules, okay? And I'm really building that structure, and I'm emphasizing to the people. Sometimes they will say, I don't want to take this thing, you know, there's too many side effects, you know, it's causing me, blah, 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 blah. Calm down. You and I need to work together. I am your worrier, helps you calm down so that I can take, it's almost like taking your car to a mechanic. You either fix it yourself or you let the mechanic fix it. I say, no, you let me do my job and you worry about something else, do some breathing exercise, all right, and let me fix your dysregulated brain so that somebody else can be effective with you. And so that's kind of the kind of thing that we kind of work on at this stage, and that's where I have most of my patients. I wouldn't say most. Those who are getting better and up, they get discharged and they're effectively out in the community setting. It's a very complex science, and it can be done. I have folks who have not had felt better for years, you know, 10 years of low-lying depression, borderline spectrum, working at University of Pittsburgh, in a very successful position, accepted that as a norm. And I said, I don't. You feel, to me, you're 50% of your capabilities, and you can do better. Well, that's what I've been getting Effexor over the years, and this seems to work, and I'm working. I said, well, if you're happy with that, I'm fine with that too. But I think that you can be better. And that's where you begin to do these crazy things, putting in something almost like a little, some other color. I'm not psychotic. Why are you giving me Risperdal? I know that, honey. You're not. But this medicine works better if I have this little salt added to that. And then it works, it becomes more effective. And it's terrible that people get all these long notes from our pharmacies anymore. You know, you thought that I had this problem. I said, no. I'm sorry you have to read that. Now you need to understand that as well. If my job is cut out because I'm trying to do the science in its best, and that's a paper to save you from a legal problem down the line. But the point here is that all these tools, SSRIs, if the response is inadequate, you can add another one. If not, you can augment that with benzodiazepines, low-dose neuroleptics. And then I have one patient on MAOI inhibitor as well. These are old medications like Parnet and Nardil and whatnot. We don't use that whole lot, but they're actually very effective treatments, and are still I think, very, very good. And then lithium and mood stabilizers. In real life, there's really no one recipe. What works for some individual doesn't work for the other. And so it's a continuous kind of a battle of trying to find the right molecules. And I think this is an important slide here. Our diagnosis may be wrong. I may be treating somebody who may have adrenal cell carcinoma, and that has happened. People had a medical disorder which was a small little tumor secreting adrenal cortical hormones, and they are in seclusion, and they are in places where they shouldn't belong. Or I have seen even people with thyroid problem ending up in ICU, and the psychiatrists were treating them for 4 or 5 years until their thyroid practically gave out, and they became thyroid in a state of thyroid coma. And it's very important to recognize our diagnosis could be absolutely off mark, and that's okay. I may have to then reconsider. I was sitting with a family, and they were telling me some things that I really was not hearing. And then the father came and he said, Dr. Chaudhary, I want you to know my daughter, before she was started on this medication, was never psychotic. This only started after she started this medication. And I said, well, that changes the whole way I need to work with her. Because if she never had those problems earlier on, the medicine may be causing her problems. Don't medicines cause problems? They cause tremendous amount of problems. These are very powerful molecules which cause problems. So we got to be cognizant of that. Am I causing problems or am I relieving problems? I have a patient, she's actually dying, and I had shared, very difficult, extremely difficult, drinking, cutting, hospitals, whatnot. And one day I took her off, and she bought like 10 medicines. I took her off of all the medicine. I said, you know what? I think some of these babies are causing you more turmoil than they're helping you. And she said, what do you mean? I'm going to end up in the hospital. Now she's on 3 pills, doing far better, smiling more, less hospital, more improvement. We just keep adding on these cogentins and viscerals and God knows what not. So if the symptoms are not from a treatment that needs to be attended, we have to reassess ourselves, stop and reassess. Okay, so that's the consensus. There's no magic bullet. If I knew, I would give you. If I didn't, I will acknowledge. And this is one of the methodology that they have been recommending. And pharmacotherapy alone is insufficient to treat borderline personality disorder, must be combined with psychosocial treatments. And so that's a humbling note. I see a lot of docs getting my own peers, they got very frustrated, and they say, well, this is a non-compliant patient, she doesn't want to get better, and that's no better than saying, I don't know what else to do, and that's a mere fact. Compassion. It's not what Mrs. Smith did yesterday to hit another staff and be hurtful to nursing aides was right. Okay? Nobody is saying that there is merits to a person's behavior which is hurtful to others. Nobody is accepting that. We are just saying is this is as best as they know how to act. And these are two different things. Okay? And Marcia in one of her video talks about that there could be an accident. Accidents happen, right? There was this tragic accident on Route 28, I think a triplet and a family were driving, and this weird thing drops out of the truck and I think kills 2 of the triplets and the father. And so one triplet and the mom is alive, and it just broke my heart. It was so sad that in a split moment, the whole life plans are shattered and the agony that descends. Not a single person in this room would say that that was the right thing to happen? Would anybody have the heart to say, oh, they deserve that, that's what the way it should have occurred and whatnot? No. But we're accepting the fact that it happened. We're not saying it was the right thing to happen, and it's okay to go back and see what could be done in future so that such tragedies do not occur again. But when it happened, it happened. Right? Can you and I change that? No. So when on my unit, my staff got hurt, it's not that the person who is doing that is doing it right, and that's our dialectic between our staff. My point is, this is as best as they knew under the circumstances what they were doing. Now, it's our goal to help them act and react better than what they have been doing all their lives. And that's very important. Otherwise, we will not have compassion. Okay? Otherwise, it's very hard. If Dr. Hoffman was bit, one of his finger is not the same now because another patient of ours bit him. Right? Was it the right thing? No. But can he work with this individual again? He is. And we're trying to figure it out that the next time she doesn't bite, she talks. Okay? All right? So it's because biting did not get her the outcomes she was desiring. All right? Biting made him angry. He's filing charges against her. She's very fearful of that. And at this point in time, she's no more skillful because she knew biting would get her out of the situation. It didn't. It got her into more trouble. And now we are working with her to understand biting is not a good skill to have. Unless you think that it's better skill. But no, you agree with me, it seems. You're agreeing with me? Okay. So we have one person in the audience who is saying, when you're angry with somebody, don't bite. Okay, this is a DBT skill that you will never learn anywhere else except here. All right. So suicidal behaviors and what happens, pre-treatment, something is good, something is bad. Just figure it out. Okay. DBT. What's that? This DBT. What's that? Pre-treatment. Okay, pre-treatment. Treatment as usual. So something is good, something is bad. A lot of parasuicide. You all know that. You're intelligent folks. I'm going to move on now. Okay. So the point here is, folks, DBT works. Treatment as usual works as well, but it's not as effective. It is effective. We're not debating that at all. But when you combine these things, it becomes more effective. That's the point. And so the studies kind of illustrate that in a goofy manner. What is this, Diane? Psychiatric hospitalization during treatment. So if people were getting DBT treatments and treatment as usual, I don't know what that means. It means DBT is better. Dissociation. Dissociation. People know what dissociation is all about? What is dissociation? Right. The reason I was saying that, yesterday during my individual, this patient, she who is overloaded with medication at this time, and as I was talking to her, she goes, and she's a very intelligent musician and a beautiful, beautiful soul. And she goes, Dr. Chaudhary, I feel myself out there observing myself. I feel that I'm over there. And I said, where is that coming from? And she goes, I don't know. I thought, well, we got to know, because it's the beautiful mechanism whereby our brain, when it's almost like a circuit breaker, when the overload is too much, then the tripper that goes off and the lights go down, right? Because we are that overloaded emotionally that we cannot handle the enormity of the emotions. So, she observes herself from a distance as if she does not exist, but she is like a little numb person at a separate setting. And borderline patients do that a lot, the dissociative phenomenons, and hopefully as they begin to become one and their emotions become more regulated, they begin to be more in than outside of their self, but that happens quite a bit actually. Okay. So these concepts will be hammered down your brain during this indoctrination sessions. Unfortunately, I'm sorry for that. because we'll be kind of going over this thing over and over again in a slightly different manner, but basically the same thing. So a person is extremely dysregulated, and I'll give you this example of mine to illustrate the point. She comes to the nursing station asking for more time of an already exhausted crew. What does it feel like, Bev, when you're there and somebody comes in the 50th time asking the same question? Could you share your feelings for the record?
Frustration.
Frustration. Never thought of that as an emotion, right? So why don't you share a bit, as you're living on that nursing station, as you work through what you work through?
It's very hard to get your work done because there's always somebody knocking on the door.
That's right.
It's usually the same people,
Mm-hmm.
and you stop what you're doing and you ask them, what their problem is, and that you try to help them. You think you've got them settled down. You leave them on a day ward, and the next thing you know, you're back. You're just getting into whatever you're doing. The door again, same thing.
That's right. That's right. So, because they're so dysregulated, there's really no amount of, that little calmness that prevails. It's almost like no matter how good you are, they keep on coming back. And then what happens, Bev? After your 51 time, the first 50 times you were very nice and professional. Now tell me the 51 time. What do you do to this patient? Now let's be honest here.
What does it do to the patient? I guess my anger level goes up a little bit. It's like
So you become angry.
rises, and it's like,
So you're getting angrier and ineffective.
right.
Okay, and what do you do when you're angry and ineffective? And she's a good nurse. Okay, and she's getting angry now. Just mind it. All right, what do you?
Walk away.
So you walk away. All right, and she follows you now. And that happened, doesn't that happen?
Yes, it does.
Okay. Okay. Then what do you do?
You have to start all over again.
Okay. No, this is the 52nd time.
I know.
Okay. So you're getting angrier, and then we end up creating an environment around the person. You never want to get better. I told you that 100 times. Just go back to where you're at. Go back to the day room or wherever that is, and then just don't bother me. Don't you see that I'm working? No matter what we do, that's not enough for you. Okay. All right. And don't try to now. At least I do that quite a bit, and I'm learning not to do that. But it's very, very difficult. So we create that invalidating environment, which proves their point. Nobody cares. See, she was trying to be nice to me, but look at, she's yelling at me now, and she can't wait to get out of that shift. Right? And then she's avoiding me. I called her 100 times, and she just didn't have eye contact. And that happens. That happens to all of us. And that's the invalidating environment that gets created on the hospital units, in the day rooms and every place, and in one-to-ones.
Are we saying, just because I'm trying to get this all straight, are we saying that the individual early on in their life has no way of validating their emotional control because of the fact that they had no emotional support, or they were
Yes.
abused, or whatever
Yes.
it was?
Yes. Very good. The question is this individual does not have that inner validation and the inner concept of emotional regulation, and that precisely is the case. The stories of their childhood are often horrific. This individual that I was talking about, about her dissociated phenomenons, without identifying too much, she was sexually abused for 12 years by an uncle, then a neighbor, and then somebody else. Under the guidance, I wouldn't say guidance, under the parental presence, which was not presence. Okay? Parents were very busy with their own lives, and actually I don't want to kind of detail the parents because I don't want to identify her. Parents are very successful people helping a lot of other people except their own daughter.
I just want to bring out the point too that not every abused child becomes a borderline personality disorder, these children have a biological, I don't know if you call it a weakness, but they are sensitive children. So you take a sensitive child and you put them in an invalidating environment, and then you have a problem. You might see a family where there's like most of the children do fine, but one child doesn't do fine. That may be because that child sort of marches to the beat of a different drummer, and the parents don't understand that child, and they basically tell the child by what they do and say to that child, you're not okay. And so the child's a sensitive child, and he's not getting any validation from his parents, he's getting invalidated, and that predisposes that child towards borderline personality disorder.
Yeah. Very well said. Diane, do you have any thoughts?
Similarly, I think that the question is often for me, my initial assumption is that every person that has borderline personality disorder has had horrific parents, and that's not always the case. The reality is some of these kids, again, are overly sensitive, and the parents or the environment just could not meet their needs. It doesn't always even have to be a parent. It can certainly be another environment as well. So it's often not malintended again. Sometimes it is. Sometimes it's not. Parents are just doing the best they can, and they actually are doing what they've done with other children. But with this sensitive person, it hasn't been effective.